that's all that dead skin removed from the patient's left ear. You can just see the bits, the consistency and the colour, the texture. And we've got a very narrow canal. I'm just using the 4.25mm specular here. We have got a smaller one, a 3.5 as well. But I just wanted to dilate this ear a bit more. And you can see the patient's ear is completely full of dead skin, dead keratin. It's not really earwax. And if you continue to watch, kind of halfway down the ear canal, so the inferior aspect of the mid portion of the ear canal, there's a residual layer of dead epithelial layer of skin there. And I decided to remove that because I wanted to know what was underneath that. Sometimes when you get these layers of skin at the base of the ear canal, or even on the anterior posterior canal wall, but more so on the inferior canal wall, underneath that layer of skin, there's a potential at least for there to be a canal Cholesteatoma. And in this particular case, you'll see yourself, it was well hidden by this layer of skin. There's a widening and an erosion of the bony part of the ear canal, and potential canal Cholesteatoma. And there was some hardened keratin there that I intended to remove, and there was some granulation tissue. So I have referred the patient onwards for an ENT opinion. Similar experiences in the past. It normally, first of all, applies some Benefit cream, I think it is, and they do a subsequent follow-up, and more often than not, a CT scan may be ordered just to rule out any underlying pathology like a canal Cholesteatoma. You'll see it all in a moment. It's quite a difficult layer of skin to remove, because the patient's ear canal as well is quite narrow. But we did manage to do it. I used a fine end suction probe. So I've more or less cleared the canal wall. You can see there's a bit of keratin a bit deep. I'm going to just change the focus so you can see the patient's membrane there, so that's intact. I have been using a bit dropped, so there's a bit of a wrinkly effect on the more lateral layer of the eardrum. So there's some more medial dead skin here, so we just suction that. And it's this portion here, so this is kind of like mid-canal. It's more or less at the juncture of the osteocartilaginous juncture. And at present, it doesn't look anything to be too concerned by. I'm just trying to gently peel the skin, but you'll see in a moment with the spec, I'm going to really dilate the entrance of this ear, so we get a really good view. You can see how dilated there, and we're getting a bit of reflection there. We did right at the beginning as well, so when you remove keratin skin, it's a very reflective surface. You can see it's very simply, we just adjusted the brightness there, the exposure, and I'm going to slowly just peel away all this almost blankets of epithelial skin. It's quite a thick spongy layer. I always think it's, where possible, it's raw. We should be trying to remove this kind of debris, especially if it's more lateral. If it's a bit more medial, I can find it can be a bit tricky sometimes. But we just don't know what's lurking underneath this. And so in the worst case, although canal Cholesteatoma is extremely rare, it would probably have gone undiagnosed if the patient has got one. And just really dilating the ear. And because you'll see the exposed bone, that's what's happened here. So now it could just be this patient's anatomy is like this. They're born with a dip in the ear canal, a little trench, and when you've got a dip like that, what can occur? Skin that migrates out of the ear gets trapped inside the pit, inside this little recess, and it can no longer fully migrate. Then you get a natural collection of keratin in the ear. And dead skin, you can see there's some granulation tissue there that I'm just removing. It just came away with this section. So yeah, when you've got an anatomical defect like this, skin can gather, dead skin, keratin can gather, and it can form into a plug, and it can get infected, and it can start eroding, literally chewing away the skin and the flesh. And chewing at the bone, so it can be very dangerous. So it could be due to the fact that the patient's anatomy is just like this, or it may have been acquired over many years with chronic failure of the skin to naturally fully migrate, or chronic ear infections. So again, this pit's not yet fully visible, but still a bit of keratin skin here. And you can start to see some of the canal wall, and here we see some exposed bone. So where I am now, the sucker, that should be the floor of the ear canal. And where I am now with the sucker lower down, this is the pit. This is the pit that really shouldn't be there. And the skin is really stubborn. It can be quite sensitive to remove. You can see you can start seeing some of the exposed bone there. And the patient was really still. She was great. She wanted me to continue to see as much as we can. But yeah, the skin is really tightly adhered, so it can be tricky to remove that and peel away. I wanted to avoid the use of any drops just in case, I'm not still sure what's underneath all this. But sodium bicarb would probably be the best type of drops to use. Now this pit's taking you can see its true size and form there. Just really dilating the ear open, just adjusting the focus. There was some embedded keratin, it was like stone, it was rock solid. I think this is the bit which I wasn't fully able to remove. And if I had the audio on, you would have possibly even heard the ping there. It's just really rock solid there. So I wasn't able to remove that today, but all the softer keloid skin keratin on this. So I'm not the level of the basic what the ear canal should be like over here. This skin is just beyond. This is almost like a cliff edge here. And this skin is on what should be the floor of the entire ear canal, and just below that you can see how it dips. And it's probably the best way to describe it. It is like a cliff edge. You see some granulation tissue there forming. So granulation tissue is in response to trauma, and during the healing process we get a build-up of connective tissue. That connective tissue then has blood supplies and blood vessels, and you almost have like a rough surface with granulation tissue. It's red normally and bumpy. So I'm just trying to remove some of this dead skin that's not in the pit. This is actually on the floor of their I assume is their normal ear, they're already ear canal before any trauma and erosion's taking place, but it's just above the pit. So this is part of their normal ear canal, it's not been eroded here, it doesn't look like anyway. It's really tough layer of skin. So I'll just talk about the WAXscope. So the WAXscope should be available in the next 2, maybe 3 months. We're just ensuring that there's a lot of quality control, and we're having our own specular. We've applied for UK patents, so we're just finishing off all the tooling for it, so we can injection mould these. We can have 4 different sizes at 3.5mm, a 4.25, which is what I'm using at the moment, a 5mm, and a 5.75. This is probably where the WAXscope's more user-friendly than an endoscope, because although the view of the endoscope, in my opinion at least, it's an rival. So our flagship product, the iClearScope endoscope, the view you ascertain from the endoscope, it's just stunning, it's incomparable. You can see there again, I've just shown removed that hardened keratin, it's rock solid though. But an endoscope does require a bit more skill to use, because you have to dilate the ear and straighten the ear using the endoscope, as opposed to the WAXscope, where you've got the speculum doing it for you, so it's definitely more user-friendly. And I would say the view that we've managed to replicate with the WAXscope is I feel it's very impressive. Obviously, everyone will have their own opinion, That's why we're uploading the video, so you can see for yourself. You can see that exposed bone there, some granulation tissue. So we're just increasing the brightness now because all the skin's removed. And this is some dead skin on the anterior canal. I think it was getting a bit of claridetic, so it did stop shortly, I think. I think a good final view. So that's of the erosion of the mid-canal. I'll just get it in focus. And we'll also have a look at a final view of the eardrum. And just to focus there. So we've instructed the patient to keep their ears dry. We don't want any water getting in there because that will just exacerbate infection and it can induce infection. So this is their right ear. So it wasn't fully occluded, but again, this is just dead skin, dead keratin. But you can probably see the texture of the skin. You get these kind of almost ribbon effect, spirally effect. And we've got a very narrow ear, but I'm just persevering with a 4.25. So again, we have got a small speculum, but the cartilage was here, so it wasn't it's a bit elastic, so there was a narrow ear canal. We're still able to stretch and dilate it using our 4.25mm speculum. So again, so just going to stretch this back to the right. There's just some skin here, so I'm going to peel that way so I can get a good view of the eardrum, but I've removed the occluding dead skin and wax. It's more just to get a view of the eardrum. I'm not very concerned about this skin, so just adjust the focus. You can see the eardrum there, extremely clear. And in a moment we're going to have that's all that dead skin removed from the patient's left ear. You can just see the consistency and the colour, the texture.